Good day to my third year. So we will continue with what we have left off last week, which was a cyanotic congenital heart defects. Today we are going to discuss the cyanotic congenital heart defects. So as we all well know, cyanosis is poorly oxygenated blood that mixes with oxygenated blood in the systemic circulation. And there are several defects that we consider as cyanotic CHDs. We have Tetralogy of Fallot, transposition of the great arteries or great vessels, Truncus Arteriosus, total anomalous venous return, and Tricuspid Atresia. So, if you heard of the term blue babies before, we are referring to these groups of congenital heart defects, the cyanotic ones. So, we'll start out with the first one, Tetralogy of Fallot. It's the most common form of cyanotic CHD and characterized by the presence of four defects. That's why it's called as tetra. Tetra means four. And what are they? Always remember PROV, pulmonic stenosis, right ventricular hypertrophy, overriding of the aorta, and ventricular septal defect. So PROV. So as you can well see here in the illustration, you can see ventricular septal defect, which is the opening in between the two ventricles, the thickened muscle, that's the right ventricular hypertrophy, a narrowed pulmonary valve, that's the pulmonary stenosis, and look at the aorta here. It overrides both the right and the left ventricles. It shouldn't be found in the middle of these two. It should only be originating from the left ventricle. So that those are those four defects. So A, again, we'll repeat. A is this one, pulmonic stenosis. B is the overriding of the aorta. C is the ventricular septal defect. And D is right ventricular hypertrophy. Why is this being thickened? This muscle, the right ventricular muscle, because of the too much blood that is building up inside this chamber. So it will exert more effort to pump blood into the lungs, but it cannot due to the pulmonic stenosis, due to that narrowed pulmonary valve. So clinical manifestations. The child will have acute episodes of cyanosis known as stet spells and transient cerebral ischemia. So they will appear blue, as you can see here in this illustration. Look at their lips, the lips of the child, the fingers and the toes. They will experience this during episodes of crying or feeding, which is known as the tet spell. So cyanosis will occur at rest as pulmonic stenosis worsens. So as it further narrows, it cyanosis will further worsen in the child. And the best position that you can place the child in is the squatting position, which is a characteristic posture of older children that serves to decrease the return of venous blood from the lower extremities and to increase systemic vascular resistance, which increases pulmonary blood flow and ease respiratory effort. Why are we doing this? In short, we let the child be in a squatting position in order to increase blood flow to the head to prevent cerebral hypoxia. Because in the squatting position, there will be limited blood flow to the lower extremities, but increased blood flow to the head and to the upper extremities, most especially the head. So children who have this will also experience low weight gain. So there's slow weight gain. And due to chronic hypoxia, clubbing of the fingers may be seen in these children. Remember, clubbing of the fingers is seen in patients who are experiencing prolonged periods of hypoxia, such as people who are suffering from chronic asthma, COPD, or chronic obstructive pulmonary disease, or any of these cyanotic congenital heart defects. They will also experience dyspnea or exertional dyspnea if, let's say, for example, after they cry or after they feed, they might faint due to the lack of oxygen circulating in the brain, or, of course, feel fatigued, most especially after feeding or crying. A pansystolic murmur may be heard at the mid lower left sternal border in this child if you auscultate him. And polycythemia may be seen later on. This is a compensatory mechanism of the body, wherein, due to the low levels of oxygen, the body's compensatory mechanism is to increase the circulating red blood cells in the attempt to gather more oxygen, but that is not the case. There is a structural problem in the heart of a child who has this disorder. So, how is the child or the child's blood going to gather oxygen from the lungs if there is a narrowing of that pulmonic valve? So, the body somehow creates more red blood cells, but it is still useless due to the narrowing of that pulmonic valve. So there, as you can see here, a person has clubbing of the fingers. So that's how it looks like. Diagnostics, the same things will be done to the echo, cardiac catheterization, angiography, CBC for the detection of polycythemia, and the arterial blood gases or ABGs for the detection of hypoxia. So medical and surgical management. Elective repairs usually performed during the infant's first year of life, but palliative repairs may be warranted for infants who cannot undergo primary repair, especially those who are experiencing failure to thrive. Total repair involves the VSD closure, infundibular stenosis, resection, and pericardial patch to enlarge the right ventricular outflow tract. So here, a palliative repair is going to be done. How is it going to be done? They are going to do this shunting, the Blalock Tausig shunting. Originally, it it was done by cutting off the left subclavian artery and redirecting it into the left pulmonary artery in order to oxygenate or for blood to reach the lungs for oxygenation. But the problem here is this the old fashioned, there will be no circulation to the left arm. So that's the problem with this shunt. So it was modified later on. It's now known as the modified Blalock Tausig procedure or the BT shunt, wherein in this procedure, the doctor will divert the blood from the aortic branch, which is here, the right subclavian artery, into the pulmonary artery, allowing blood to flow to the lungs in order for oxygenation. So they're going to use a graft instead of using the left subclavian artery. So this one is already outdated, the old procedure. This was started at around 1950s. But the modified is the better one because we are not, or the doctors rather, are not cutting any major arteries from the child. So with this, since blood is not flowing through the pulmonary artery properly, in order for blood to flow through it, since there is a narrowing in the pulmonic valve, they will create a shunt from one of the branches of the aortic arch into the pulmonary artery so that oxygen or blood rather can reach the lungs for oxygenation. So here is another illustration of that modified Blalock-Tausig procedure. And this is going to be the total repair of children who are suffering from um, from Tetralogy of Fallot. And in order to do that, they are still going to create a shunt, like what I've mentioned here earlier. They will close the VSD, do some resections, and place a pericardial patch to enlarge the right ventricular outflow. Now we go to toga or togiv, transposition of the great vessels or great artery. This is a type of defect wherein the pulmonary artery leaves the left ventricle and the aorta exits the right ventricle. And there's no communicating or no communication between the systemic and pulmonary circulation. Associated defects here would be septal defects such as PDA or PDA rather, ventricular septal defect or PDA, which will sustain the life of the child. At the left side is a normal heart. The right side has the toga or the transposition of the great arteries. As you can see here, the arteries, they are, instead of the pulmonary artery originating from the right, it is originating now from the left side of the heart. And the instead of the aorta originating from the left, it's now originating at the right side of the heart. So how is the circulation going to be in this type of heart? So unoxygenated blood from the vena cava will go into the right atrium, down the tricuspid valve, right ventricle, pulmonic valve, and then the aorta. What did it bypass? It bypassed the lungs. Remember, the aorta is going to be the one, or it's the main branch of the arteries that will supply the rest of the body with oxygenated blood. But with this defect, it bypassed the lungs. So, how is the child going to have oxygenated blood now? What happens in the left side of the heart, however, so lungs going to the left or to the pulmonary veins, draining it into the left atrium, going down the bicuspid valve, left ventricle, in, and instead of going into the aortic valve, it's the pulmonic valve instead. And it will be recirculated into the lungs for oxygenation again. So oxygenation only occurs at the left side of the heart. It does not go to the rest of the body. But this PDA or patent ductus arteriosus will somehow allow a small amount of oxygenated blood to pass through it. But it's still not enough for the growing body of an infant. So clinical manifestations is in infants with minimal communication or no associated defects, there will be severe respiratory depression and cyanosis, which is evident at birth. And I had I have a cousin who had this when he was still an infant. He's currently in the U.S. and when he was born, they were born twins. He has a twin sister, but when he was born, it was found out that he was suffering from this transposition of the great arteries. So what they did was they immediately performed surgery on him to correct this, or else he is going to die because of this defect since there is little to no oxygenation of the body at all. So in infants with associated defects, there's less cyanosis, but the infant may have symptoms of congestive heart failure. No murmur or presence of murmur that is characteristic of associated defect. There's of course easy fatigability and failure to thrive. Weight gain will not be possible with this type of defect. There's inability to suck and there's hyperpnea. So there's an increased carbon dioxide in the blood of a child who has this. Diagnostics, the same ones will be done, same as the cyanotic ones. And the medical surgical management is to give prostaglandin E. Prostaglandin E is administered in order to keep that patent ductus arteriosus patent. It will keep it open in order to allow the mixture of oxygenated and unoxygenated blood in the pulmonary artery. And within the first week of life, which is which will improve the child's well-being, an arterial switch procedure known as the Jettine procedure is going to be done. This is a corrective um, transposition of the great arteries. So this is how they do it. They are going to incise both great arteries. So this is done as an open heart surgery again. So once they incise this or a resect, they are going to attach these great arteries into their respective origin. So the pulmonary artery will be attached into the right side of the heart, while the aorta will be attached to the left side of the heart, correcting it. They're also going to correct the attachments for the coronary arteries, which should be with the aorta, in order to supply the blood with oxygen, of course. So this is the heart circulation. These are the two abnormal circuits present in the child with transposition of the great arteries. One is oxygenated, the other one's unoxygenated. And this defect is bypassing the lungs. But with this procedure, this is a palliative procedure that is done in order to allow the blood to flow into the pulmonary trunk for oxygenation. This is post mustard operation. Hello, hello, mic test. So going here, the systemic venous blood is directed into behind the baffle into the left atrium through the mitral valve and out the pulmonary artery to the lungs. Pulmonary venous return is directed over the baffle into the right atrium through the tricuspid valve and out into the aorta. But remember, this is really not a corrective procedure, unlike that of the Jettine procedure. So this is also one of the procedures that they are going to do with this defect. Now we go to Truncus arteriosus. It's the failure of the normal septation and division of the embryonic bulbar trunk into pulmonary artery and the aorta. This results in a single vessel that overrides both ventricles. So as you can see here, somehow the aorta and the pulmonary trunk is fused together. That's Truncus arteriosus. So it's fused together. And what happens here is there is further mixing of oxygenated and unoxygenated blood. So clinical manifestations of this disorder is neonates with this defect typically appear normal. However, as pulmonary vascular resistance decreases after birth, severe pulmonary edema and congestive heart failure develop. There will be marked cyanosis, especially on exertion later on, as pulmonary vascular resistance will decrease. Signs and symptoms of heart failure may also be present, such also there will be left ventricular hypertrophy, dyspnea, marked activity intolerance, and retarded growth. There was a loud systolic murmur that is best heard at the lower left sternal border, and it will radiate throughout the chest. So remember, it's found at the lower left sternal border. Again, this will be done through surgical repair. Palliative treatment, so pulmonary artery banding, will be done to relieve pulmonary hypertension And the corrective treatment here is to close the ventricular septal defect. So truncus originates from the left ventricle, and they are going to create a pathway from the right ventricle. So they are going to remodel this abnormal blood vessel here. Do some grafts in order to remodel this instead of it being a single blood vessel. Next, we have total anomalous venous return. There's an absence of the direct communication between the pulmonary veins and the left atrium. And the pulmonary veins are attached to the right atrium or to various veins draining towards the right atrium. So you can see here, this is the normal heart, but for total anomalous pulmonary venous return, it doesn't go back to the left atrium. It is going to the right atrium instead, as you can see here in this illustration. So is the child oxygenated um with blood? There's again mixture of oxygenated and unoxygenated blood happening here, since it doesn't go back properly to the left atrium. It bypassed it, or it was redirected instead, not bypassed, redirected into the right atrium instead of the left atrium. So there are several types of defects here related to this. So clinical manifestations, we have cyanosis, pulmonary congestion, and heart failure. Murmur is also audible. Management, surgical correction again involves restoring the normal pulmonary venous circulation. They are going to cut the pulmonary veins from its attachments and connect it to the left atrium via homografts. So cut this one. Cut it and reconnect it to the left atrium. They will use homografts if there's not enough um, vessel to redirect or properly direct the blood into the left atrium. Now we go to tricuspid atresia. This is the failure of the tricuspid valve to develop during embryonic stage. So, meaning there's no communication between the right atrium and the right ventricle. Associated defects like ASD or patent foramen ovale and VSD or PDA is present. And a child who has this has a small right ventricle, but a large left ventricle and a decreased pulmonary circulation. So as you can see this illustration here, the normal heart is on the left side. The abnormal one, the tricuspid valve, didn't develop. So there's a closure in between the right atrium and the right ventricle. So it's how is the blood going to flow through it if there's no valve present? Again, clinical manifestations is cyanosis because the blood is not passing through this. It will pass through the atrial septal defect instead. But did it bypass the lungs? Yes, it did. So there's no oxygenation. Tachycardia and dyspnea is present, and older children may have signs of chronic hypoxia, such as having clubbing of the fingers. Again, palliative procedures will be done, such as pulmonary to systemic artery anastomosis, and they are performed on children with congestive heart failure. And corrective surgery may be performed by using the Fontan or Hemi-Fontan procedure. So here, what they are doing here in the surgical management is, instead of connecting or the vena cava connected into the right atria, it will be connected instead into the right pulmonary artery. Right pulmonary artery. In order for the blood to go into the lungs. So, or another type of procedure is they are going to create a conduit. They're going to get a blood vessel graft. and attach it into um, the inferior vena cava and connect it to the pulmonary artery in order for the blood to be oxygenated, therefore bypassing the right ventricle, the pulmonic trunk, and so on, so that oxygenation is going to occur. So that's how they repair this type of defect. Now we go to the last one, hypoplastic left heart syndrome. There is underdeveloped or non-functional left ventricle. See, there's no left ventricle existing in this type of procedure. And there is positive mitral or aortic valve atresia. So there's atresia, there's a closure of both the mitral and or the aortic valve. So how is the child going to survive with this procedure? Usually, for children who have hypoplastic left heart syndrome, the prognosis of this is very, very poor. They are going to immediately die from this type of congenital heart defect. The only option that they have with this type of congenital heart defect is heart transplantation, because we or the surgeons can no longer correct this type of defect found within the heart of the infant. They need a new heart with this type of defect, or else they are going to die. Prognosis here is very, very poor. So now we go to this general principles of caring for patients who have congenital heart defects to prevent CHDs from occurring. Of course, number one, mothers need optimal nutrition. They need to have prenatal care and avoid drugs or any alcohol. And immunization against rubella and avoidance of infections that are considered as teratogenic. But take note, immunization against rubella should be done before they get pregnant, or else that vaccine may have harmful effects with the fetus. They should maintain respiration as well, proper positioning first upon admission for patients who have CHDs. Place them in an orthopnic position for the acyanotic type, squatting position for older children with cyanotic CHD, and knee chest position for younger children, for infants and toddlers with cyanotic CHD. We need to perform suction and oxygenate the child as needed. Next, number 3, we need to keep the patient warm. Cold stress, because cold stress, remember, when we are cold, our body is going to shiver. That will create increased metabolism inside our body. Therefore, more oxygen will be needed because of the shivering that we are experiencing, which will therefore further increase the cardiac workload, causing respiratory distress to occur. So avoid extremes of temperature, most especially cold temperature. 4, promote rest. So we need to have a well-planned nursing care, formulate those NCPs. Anticipate the needs of the child, most especially the feeding needs of the child. Give small, frequent feedings. Gavage feeding as needed, primarily to promote rest, because infants who have cyanotic heart defects will appear very weak to perform feeding. Remember, their energy is focused in feeding. With CHD, the cyanotic type, they will feel too tired to perform feeding. And they should have enlarged nipple holes or soft nipples for bottled or formula milk for easy feeding of the infant. And to prevent infection from occurring, number 5, hand washing is very, very important here as well, together with immunization and check for any signs and symptoms of infection such as fever. and we need to report this immediately. Next, maintain nutrition and hydration. We give high protein and vitamins and minerals, especially iron, because iron is needed by these infants in order to promote the oxygen binding capacity of the blood. Small frequent feedings would be needed by these children, and non-constipating foods that are high in fiber. Gavage feeding, we've already mentioned that earlier, and monitor the patient's intake and output. We need to weigh the patient daily as well. 7, administer ordered drugs. If there are antibiotics, these are given to prevent the occurrence of infection. These are prophylactics. Diuretics, if there is congestive heart failure, especially if there are signs and symptoms of edema. And digitalis as well. Digoxin will be given to the child who has heart failure. Now, nursing responsibility for giving digoxin to the patient. Check first the cardiac rate before giving digitalis. If bradycardic, withhold the drug and refer it to the physician. It is very, very important to check the heart rate of the patient before giving digoxin or the brand name Lanoxin. If the dose is missed and more than 4 hours has lapsed, withhold the dose and give it at the regular time. The child vomits within 15 minutes of giving the drug, give the same dose. If more than 2 consecutive doses are missed, we need to notify the physician. Check serum digoxin levels regularly because the serum digoxin level should be maintained at 0.5 to 2.0 nanograms per milliliter. And prepare the child and family for various diagnostic and treatment procedures, including surgery. Now, for the parents, we are going to encourage verbalizations and concerns because they will be very, very worried about their child who has CHD, and most especially if their child is going to undergo a major cardiothoracic surgery. Since majority of the surgeries I've mentioned here are open heart surgeries. And we need to allay their anxieties by letting them speak, like letting them voice out their feelings in order to relieve them from their anxiety. Accept family or children reactions as well and provide psychological support. So that's it for the cyanotic congenital heart defects. If you have any questions about my discussion for this, please do not hesitate to send me a message. I'd be more than glad to help you out with those things. Again, thank you for joining today's lecture on congenital heart disease. You will be having another round of quiz with regards to the cyanotic heart defects. Again, thank you and have a great day, guys. See you again next week.